everyone. I am Gretchyn Bailey, and I am a fellow of the American Academy of Optometry. I am joined today by Nora Lee Cothran, who is also a fellow of the Academy, as well as a glaucoma specialist at the Eye Institute of West Florida and a former intelligence officer in the Air Force. Hi, Nora. Thanks for joining me today.
Hi, Gretchen. Thanks for having me.
So today we are going to talk about visual fields, specifically a recent study which was titled The Association Between Longitudinal 10-2 Central Visual Field Change and the Risk of Visual Acuity Loss in Mild to Moderate Glaucoma. And this study was conducted by Wu and colleagues and appeared in the July 2023 issue of Journal of Glaucoma. This retrospective observational cohort study aimed to examine whether longitudinal 10-2 central visual field change is associated with the risk of visual acuity loss in glaucoma. Nora, can you tell me, how does visual acuity reduction in patients with glaucoma correlate to visual field results?
You know, this is really interesting because I was actually shocked to see this paper and publication, not because I was shocked by the results, but the fact, because as optometrists, you know, refraction is our bread and butter. Understanding acuity is our bread and butter. And so to know that up to this point, there had been no major papers that had been published that evaluate that central 10-2, that central 10 degrees of vision and how it correlates to Snellen was really surprising to me. And I'm so glad that the data is out there, because it actually matches what I found clinically in my clinical practice of seeing all glaucoma and neuro eye disease.
Were there any limitations to this study?
You know, there were. Even though the volume of patients in the study was a significant amount, the actual number of patients with severe field loss was not as robust to actually give, I think, an accurate representation of what happens in time with these patients.
So what do these results mean for the treatment of glaucoma?
These results correlate with what I see clinically. I think that optometrists and ophthalmologists, anyone that's managing glaucoma, needs not only a baseline 24-2, but needs a baseline 10-2 within the first few months of managing a patient, regardless if they're on treatment or not. I have patients within my clinical practice that will have glaucoma hemifield threshold within normal limits on a 24-2. And yet when the visual acuity is best corrected to 20/30 and there's no underlying retinal pathology or no other reason for it, I run a 10-2 and I will find a central scotoma. And so I think that as optometrists, we are much more cognizant to identify these types of patients. We know that the loss of vision in that central field, actually, I know that it correlates with Snellen. And to me, roughly clinically, outside of this paper, for each quadrant of that 10-2 that starts to go, I've noticed that patients will lose about 2 lines on the Snellen. This is extremely important because a patient can have all of their peripheral field mostly intact, but if they start losing that central 10-2, that's that person's quality of life, their ability to see faces, read signs, read their books. I mean, it is extremely, extremely important to monitor that central field of those patients, because it directly relates to their vision and directly relates to their quality of life.
And Nora, tell me, why is the results of this study important to optometrists?
I think it's important to optometry because, as I mentioned, we are very aware of what the best corrected potential acuity should be. A patient that has no other underlying pathology should always be correctable to 20/20. And we are the experts in that. And if a patient cannot be correctable to 20/20, there has to always, always, always be a reason. And if that practitioner may not have the tools within their own clinical practice, send out to another optometric colleague who has some of those tools to investigate, including a 10-2, or if they need a VEP or other types of testing to start to investigate that visual pathway. But as colleagues, I think it's important to the profession to rely on one another, because if a patient's not correctable to 20/20, there has to be a reason for it.
That's great, Nora. Thank you so much for joining me today.
Thank you for the opportunity to talk about my favorite subject.